Hello, everyone. Welcome to Asia Nova Seminar, organized by Arthroplasty Society in Asia. This program is designed to establish a professional arthroplasty firm that arthroplasty surgeons from all over the world can be connected to share their personal ideas, clinical experience, and cutting-edge techniques. I'm Dr. Bao Chaoji from the First Affiliated Hospital of Xinjiang Medical University. I'm so privileged to moderate the first episode of ANS Season 4. And in this episode, we will focus on some innovative care choice for treatments in PJI patients. We will discuss the choice for treating infection in revision arthroplasty and discuss what is the better way to keep functioning in PJI patients. So for innovative medical interventions methods. On behalf of Asia, today I feel honored to have two French special guests here, Dr. Tristan Ferry from Hospice Several the Line and Dr. Sebastian Lustig from Line Crossroads University Hospital.
Hello. Hello, I am Tristan Ferry, and I am very happy to co-chair this seminar with Dr. G. Today, Dr. G and Dr. Lustig, who will present two different treatment choice of revision, total joint arthroplasty, and then we will have a 10-minute discussion for each topic. There will also be a discussion part at the end, and it is also welcomed to have your questions. Then we can discuss later after the seminar. Now let's get started with Dr. G, who will speak about the choice for treating infection and especially one-stage revision arthroplasty. Please, thank you.
Thank you, Professor Ferry. So first, I'm going to talk about my topic. For treating chronic PJI one-stage revision. Since we have performed the one-stage revision for more than 20 years, and so today I'm here to share our experience and opinion. No special disclosure, and as we all know, periparasitic infection has not only represented a serious concern for surgeons, but also importantly, it destroys patients' whole life absolutely. That makes them lose everything they have. Once the chronic infection has been identified, the mandatory principle is the physical eradication of all organic and non-organic material that is dead or infected, followed by immediate or delayed reinfectation. Be it one stage or two stage is always the strong center of this debate. One-stage revision technique has been proposed by Professor Bullhouse from Endoclinic in 1981 as a two-in-one technique. It has clearly defined infection control rates and promised life morbidity, mortality, and functional impairment, as well as higher satisfaction. However, one-stage revision was not initially widely used due to limited experience in treating PJI. Concerning about the theoretically higher recurrence rate of infection. Additionally, rapid development of symptomless persistence in those years is another reason. So the two-stage revision was considered as the gold standard in treatment of PJI because much safer for both patients and doctors. However, more and more problems from the two-stage revision have come to the light after many years. First, they may get an overestimated infection control rate. The recent study reported that there are 15 to 18% patients did not undergo reimplantation at the last follow-up. And the actual success rate is only around 75%. In cemented space, it cannot provide high antibiotic concentrations for a long period of time, which may similar to ICV produced, which is the main reason to increase the bacterial resistance to antibiotics. Next point, whatever CRP, ESR, aspiration, or alpha defensive, from now on, we have no consensus standard for determining the optimal time of reimplantation. The patient have to take the space-related complications, such as fracture, dislocation, and cerebral loss. And even after 4 to 6 months treatment period, patients get similar functional results to one stage, but to obviously these patients pay more. And besides that, there are more and more papers emphasize that even the two-stage were rare, but relevant mortality need to take more consideration. At last, if the two-stage revision failed, the repeat operation seems like take the patients to the end of the road. In the past 15 years, with the increasing experience in treating PJI, the continuous improvement of passenger culture technology, and the improvement of the perioperative treatment protocol, and the growing evidence of efficiency of one-stage revision, this neglected technique has returned back and is gradually being accepted by more and more medical centers around the world. Let's see the number. The number of one-stage procedures in Sweden during the past 20 years has potentially increased 5%, and the number in Germany also increased 60%. And the data from National Joint Registration for England and Wales show the use of single-stage revision in hip and knee both increased around 20% from 2005 to 2014. And after searching the PubMed, the number of literature on one-stage revision published over the past 5 years increased 64% when compared to the period between 2013 and 2017. We have more than 400 infected cases undergone one-stage revision since 1997. A proven treatment system has been established gradually, and this approach has performed in over 95% of all our chronic PJI patients. Besides these exclusion criteria, the fungal infection, negative PJI, multi-drug resistant bacteria are all included as our indication of the one-stage revision. A joint aspiration has made preoperatively in all patients after a minimum of 2 weeks of antibiotic therapy, and the duration of the culture has extended from 5 to 21 days according to the culture results. We have divided our technique into 3 steps. The first step is aggressive development. We did the mechanical development first, and since 2021, after mechanical development, an 8mm handheld non-contact low-frequency ultrasound probe was used for ultrasonic development in the whole surgical area for 5 minutes, and each ultrasound lasted 10 seconds with 3-second interval. All soft tissue and bone interface in the surgical area was sonicated by the probe, including femoral and tibial canal. And our preliminary short-term follow-up results were just published last month, but as a novel treatment for PJI, the further comprehensive study design and a longer follow-up time are essentially needed. After mechanical development, the surgical area was exhaustively irrigated with large saline and hydrogen peroxide, and so all the soft tissue was soaked in 0.5 aqueous bathing for 50 minutes. The second step, intermission, the whole surgical step area was re-sterilized and re-dripped, and the surgical team re-scrubbed, put in the new gowns, and exchanged the entire set of surgical instruments. Now, after this, we go into the third step. After further positive lavage, a new cementless prosthesis was subsequently implanted in all infected hips, and the new cement implant was used in all infected knees. And we performed the intraoperative direct sonication of implants and soft tissue since 2021. A physician assistant scrubbed in on new gowns and wear double-scale gloves to perform sonication procedure, and they remove the prosthetic components, and all suspected infected soft tissue were directly sonicated in a small metal container and without sonication tube during the operation in OR. And the sonication fluid was then immediately incubated in blood bottles in the operating room and cultured in bacteriology 3D blood culture system. And our study of this new culture method just accepted by GBGS, and the details will be presented in the next few weeks. During the operation, we poured biomass and powder into canal and removed before closure. After the surgery for culture-positive patients, sensitive intravenous antibiotics have been administered for at least 2 weeks for patients with fungal infection or multi-drug resistant organism. Besides systematic antibiotic treatment, we also use direct intra-articular antibiotic infusion and once daily. And for culture-negative PJI, 500 milligram vancomycin received intravenously every 12 hours for an average of 14 days. And besides that, just as the picture showed, we use a 3-branch catheter approximately for intra-articular antibiotic infusion after the operation. And in this way, the metrophenate and vancomycin alternately used in the morning and afternoon, respectively. And this variable is 3-branch catheter approximately for intra-articular antibiotic infusion. And the yellow one is drainage tube distally. And before each injection, the distal suction drainage is flat, and the whole local antibiotic procedure is performed using a stir technique. The 3-branch catheter is sterilized by 75% as alcohol and 0.5% chlorine added 3 times. The synovial fluid is extracted from the proximal 3-branch catheter for biochemical testing, and the antibiotic solution is injected through the proximal catheter into the infected joint. After injection, the proximal catheter is placed on the plain dressing, and the proximal catheter is then covered by another 10 layers of gauze. And with this protocol, we got a 64% success rate in 11 patients with fungal infection, which comparable with the results of 2-stage division in other studies. For culture-negative PJI, after a minimum of 53 months of follow-up, we got a 90% success rate and found no significant difference in the infection control rate between culture-negative and culture-positive group. Even with this broad inclusion criteria, we still got a 89% infection control rate after a minimum of 58 months of follow-up. And recently, we retrospectively reviewed the patients who had undergone multiple pair surgical interventions. The 7 years infection-free survival was 87%. So this is a 15-year male who got a 5 times operation, including multiple deployment exchange spacer and with RIF. We did 1-stage revision for him, and the intra-articular antibiotic injection after operation. This is 2 years follow-up. And in recent years, there have been ongoing studies of new extensive data in both joint registration system or the meta-analysis indicating that 1-stage and 2-stage revision have similar infection control rates and post-operative function. But finally, let's talk about the money. The study in GBDS showed the 1-stage revision was more cost-effective in both disease trees by producing less cost per PJI gain. And the conclusion said that despite 2-stage revision being considered the current gold standard for infection irrigation in patients with PJI following TKA, and optimal decision that produced the highest quality of life was 1-stage revision. And last year, the study from Australia showed the incremental cost effectiveness ratio of 2-stage exchange compared with 1-stage exchange was 231,000 per QLY. And the conclusion says that the adoption of 1-stage septic knee revision is the optimal choice for patients who have a PJI and who do not have a compelling need for a 2-stage exchange arthroplasty. And a 1-stage revision for PJI should be advocated. And the growing of global population, energy crisis, war, and the global pandemic are putting the world economy under unprecedented pressure. And in this situation, and this slide may no longer be appropriate, it's time to change the traditional concept of the gold standard. Different treatment protocols should be selected for individuals according to the principle of optimal cost effectiveness in current time. And is this only the change of the segment spacer? I don't think so. I think that's the change of treatment standard. And a 1-stage revision for PJI is a reliable treatment option with a higher rate of infection control and less morbidity functional impairment, which may considered as a new golden standard for treatment of chronic PJI. That's all my talk. Thank you.
Thank you so much, Dr. G. So let's move to the secondary part. And the second speaker is Dr. Sebastian Lustig. I'm very happy to introduce him to Asia audience, especially as I am working with him every day. Dr. Sebastian Lustig is a knee and hip arthroplasty surgeon in the Croix-Rousse Hospital, the same hospital as me, in the Lyon University Hospital called Hospice Civil de Lyon. He is chair of the Arthritis and Joint Replacement Department in our institution. He is vice president of the French Hip and Knee Society. He is ISACOS Board of Directors. He is deputy editor of the Journal of Bone and Joint Infection, Journal of Bone and Joint Surgery American. He is chief editor of the Psychot Journal. He is a knee society board member. So let's welcome Dr. Sebastian Lustig to talk about the choice for treating infection, two-stage revision arthroplasty. Thank you, Sebastian.
Thank you very much, Tristan, and thanks a lot to Asia to allow me to share our experience about two-stage revision. This is definitely a very complex topic, and we heard already that you have different options when we talk about how to manage chronic PJI, and two-stage revision is one of the option we can use. We heard already that one stage is getting a lot of popularity, and these are our numbers in Croix-Rousse, and you see that also we are moving slowly towards more one-stage revision, but we still do a significant number of two-stage revision. I think it's very important to understand indications and how to do this. And you have very, traditional contraindication for one stage for us. And these things have been discussed at the International Consensus meeting in 2018 with all, the experts from all around the world. And we've worked there with Tristan Ferry together, listening and discussing this topic. And we believe at that time that when you have, systematic sepsis, when the host is not allowed to fight against infection, when you have unknown organism or resistant organism or post-soft tissue coverage, and that's very important. These are not optimal conditions for one stage. So this is a typical example where in our, experience, it's really hard to offer one stage revision for our patients. And in this situation, when you have compromised extensor mechanism, poor soft tissue, you have to consider free flap, static spacer, and then second stage with, constrained implant. And these situations for us have to be managed with two-stage fashion. So in history, why are we discussing two-stage? Because, John Insall in 1983, so, a long time ago, 40 years ago, described this about 11 patients, very small series. And he was saying that antibiotics alone do not work and there are no shortcuts. So it does take time, it does take two-stage to be efficient for revision. That's history. But now with time, we understand that you have some features that are hard to, fight if you don't, consider two-stage. And biofilm is one of the reasons why we've been, considering for a long time only two-stage revision. Because when you see this picture on the bottom right, you see the biofilm on the implant, and it's really hard to, consider curing this problem without, changing the implant and having very strong antibiotics to fight against this. Also, we know that, some organisms are more resistant than others, and that's where, surgeons, are sometimes afraid of considering one stage and move toward two stage when they, want to treat this situation. This is also very nice paper from GBGS showing 86% eradication rate with, two-stage revision. So let's go back to, evidence and the huge amount of work done thanks to Jay Parvizi and Thorsten Gerke a few years ago in Philadelphia, and what the evidence is showing us regarding indication for two-stage exchange seems to be a reasonable option for treatment of PJI in specific conditions. As I said, when you have systematic manifestations of infection, when infection appears obvious, but you have no organism identified, if preoperative cultures identifying, difficult to treat or antibiotic resistant organism. If you have a sinus tract, and of course we can discuss that. And if you have inadequate and non-viable soft tissue coverage, as I showed in the previous example. So why two-stage? We discuss, implants and biofilm. So it means that if you go for one stage, you have to do extensive bony resection, and that might be less conservative. And when we're going to discuss function, management with Tristan Ferry a little bit later, we'll see that function is very important. And also because when we talk about biofilm, sometimes it's on the implant, but sometimes also can be in the bone. And then you need to make sure that you remove enough bone or you sterilize the infected bone around the implant. And that's where you might think that two-stage can be useful. So how do you do this? So the gold standard description from John Insall is, you remove everything. You have, debridement, and then you have a free period with intravenous antibiotics, and later you come back for implantation. How much time do you have to work? The, historical description is 6 weeks of IV antibiotics followed by reimplantation. So what's very important? The first step, we know that what's number one is to identify, the bug. And so get appropriate samples, do it, nice, and very cautiously work with a very strong team. Multidisciplinary team is very important when you talk about how to treat infection. And debridement is crucial. I like to show this because, that the surgical aspect is very important. So first get samples. This is crucial. And then you need to get appropriate exposure. And this is not the time for mini-invasive surgery when you have to deal with infection. With arthroplasty, you need to see what you do. You need to know how to expose, how to approach. You need to do a proper synovectomy. It does take time. This is not something you can manage, in 15 minutes. This is a surgery that needs an experimented team, and also that you do the surgery with no rush. That's very important. So take the time to remove all the soft tissues that are infected. Don't rush, to remove the implant first. You take the time to leave the implant in, do a proper synovectomy, and remove all the soft tissues carefully. And then you remove the implant, and then you can, put the spacer in. We will see how. So removing the implant is something, but also you have to remove all the cement. Sometimes it's easy. Sometimes it can be really tricky. You can see here an example of an implant performed, 20 years ago. This is really hard to remove. You need to know all the tricks to be able to open the tibia, open the femur, to remove all, the implant and also the cement mantle, even in this challenging situation, and without destroying everything. We mentioned, ultrasound. We also like to use this technology to remove the cement mantle. You can see here how this ultrasonic technology is useful, especially when you have long keels. That's true for revision hip and for revision knee as well. We do a lot of second or third revision when you have long cemented keel with rotating hinge implant, and you see how you can get good access to all the bone using this technology. Then you have to manage, as we say, cleaning all the soft tissue. You have to evaluate how much bone loss you have. So that's very important. Once you finish, removing all the dead bone, all this done with synovectomy and intensive washing, to know, how much bone is remaining, just to plan the second stage. So the third step is, really cleaning everything and making sure that what's going to be the starting point next time you're going to come back for the reimplantation. Then spacers. We discussed that spacers can sometimes create some problems. What we like to do is to use cemented spacer with a high, dose antibiotics, but also we use some cement with methylene blue which is going to be a low quality cement, but very useful to get some fixation of the spacer, so you can allow the patient partial white bearing and also mobilize the joint. It's very useful for the knee, because then when you come back for the second stage, you have an easier surgery, because you still maintain some range of motion compared to static spacer. So you have different options, but the key with the spacer is to maintain soft tissue tension of the articulation during the interval between debridement and reimplantation in the two-stage procedure. So the spacer, that's the aim of the spacer, and also to provide local antibiotics, which can, of course, be very useful. Two different ways to consider this. When you do a mobile spacer, you use high viscosity, 2 doses for the tibia, low viscosity for the femurs, because if you don't want to wait too long, you measure the size to make it match with the implant you just removed. Make sure that the thickness is sufficient. You need to have appropriate thickness of the tibia. This is a typical example of a bad spacer when you see how it breaks because it was not thick enough. And you might have short stem if you want to stabilize it a little bit. If you want to do a fixed spacer, you can use a pediatric nails or thoracic drain, and you put cement around it. That's to catheterize the femoral and tibial shaft, and then you use cement in between to maintain the space. That's a technique we use when you have compromised, extensor mechanism or soft tissues, and when you need to stabilize the knee during, the free flap, procedure, or if you want to make sure you're not going to put it more in danger the extensor mechanism. So that's the situation where you use this kind of spacer. Of course, we mentioned the option of using, an implant, temporary implants as a prostalac, procedure. That's also easier because it allows the patient to white bear, and it does facilitate reimplantation. You have this nice paper from Gil Scuderi showing it might be an efficient and also create less bone loss. This is also another option. The problem is you have less cement, so less antibiotics. So we can discuss the efficiency regarding, treating infection. So 2 different options when you want to use mobile spacer. What's very important is to consider wound closure and doing the job with the plastic surgeon at the time of, the first step when you remove the implants. Don't necessarily wait for the second stage. So quite often we do, the synovectomy, we remove everything, we put the spacer in, and we do the flap at the time of the first step to make sure that we have good healing of the soft tissues. Of course, it's a discussion with the team. It's not only one surgeon, it's a multidisciplinary team decision. Then we wait for the microbiologic diagnosis. You adapt, the antibiotics, and you consider the in-between phase with rehabilitation, and you make sure there is normalization of biological parameters. We can discuss that. Antibiotic adaptation, that's crucial because we use very, active antibiotics, but sometimes you have, a skin reaction, like in this, example. You need to make sure you know how to manage that and choose optimal time and length of antibiotic therapy. Usually in most publications is 4 to 6 weeks. It depends, of course, of the bugs. And you have, of course, to adapt to the results of the culture and the sensitivity of the microorganism. And also, every patient is different. You will not manage a skinny guy like this and a more obese woman like that. The condition in between might be different. Probably for him, it's going to be easier to consider partial white bearing, more challenging for overweight patients. But you do have to mobilize them and consider IV antibiotic therapy. Also, that's the right time if you work with a strong anesthetic team, and we published this paper with Tristan Ferry and Misha Jatsko, showing that it's the right time to consider, a blood management strategy and make sure that you optimize the patient. So you are in an emergency situation, you remove the implant, and then you have time in between case to consider, blood management and see how to also optimize the patient. So when you go back for reimplantation, you are in the, perfect, timing and also perfect condition to have the optimal outcome with the procedure. And when we did this study, we realized that actually doing this, you significantly, decrease the number of complications during second stage reimplantation. So how long, should we wait? So these are some of the questions answered during the consensus meeting in Philadelphia. What's the optimal timing when you consider a 2-stage, exchange? Well, the timing is not something, universal, so you have to consider resolution of the clinical signs, and downtrend in the serological markers. You will not go back to normal numbers, but it does have to go down. If it doesn't go down, you might have to consider going back, doing a spacer exchange, another synovectomy, and consider then waiting another couple of weeks before going for the reimplantation. We asked the question about normalization of the serological markers, which is it necessary prior to reimplantation arthroplasty when you do a two-stage, and it was quite clear that only a trend and a decline in CRP and ESR is expected, but there is definitely certain cases in which reimplantation may be performed despite abnormal levels of ESR and CRP, so we should not wait for complete normalization before going for reimplantation. So how long? Well, it varies from short, very short, like 2 weeks to several months. Really depends on the bugs and the local situation. But more than 6 months will definitely lead to suboptimal functional results. So we don't advocate for, longer interval like it was in the past. Then comes the time of the reconstruction. You have to manage, again, surgical approach, implant, joint line, which is tricky, especially when you consider totally revision, bone loss, and extensor mechanism plus soft tissue coverage. So during reimplantation, you need to consider that the patient is still, infected. So again, you do a complete synovectomy. You do the same things I showed you in my first video. It's not easier. You have to do it very carefully. You have to remove all the spacer components and don't leave some cement piece in place. You again have to debride, irrigate the wound accordingly, and use also a low-dose antibiotic, loaded cement when you do the reimplantation. So you have different options. Now you have a dual antibiotic loaded cement, which is quite, interesting. And we have current studies ongoing in the department showing that it might be beneficial in this scenario. And then consider that's for the knee. Of course, for the hip, we use more and more cementless. So it's a different option. What is tricky for the knee is restitution of the joint line. So you have some tricks. The drill pinpointing technique is quite useful because when you go back after 5 or 6 weeks, it's really hard to know exactly where is the joint line. So don't hesitate to use these very simple tips and tricks for that. And then soft tissue and extensor mechanism is also very often, a little bit in danger. So you have to know how to use all these different options, going from the Hansen, synthetic graft to the allograft, and sometimes we have to use arthrodesis implants because there's no way to maintain mobility of the joint. Bone loss is very often, very often to be managed. Now with trabecular metal, we have a lot of, different way to improve the primary and secondary fixation. Thanks to this material. And also we do use, quite often, megaprosthesis tumor implants. So you have specific implants that has to be used and understood when you consider this two-stage, strategy. This is a, extreme example when this patient, had several two-stage revision. You can see that it was not optimal because you still have the one plug here, plus another one here, plus the remaining cement. So you understand why. Obviously, it didn't work. So you have to do extensive bone resection, synovectomy. So you have a huge spacer in between that you can see here. And you had to use this huge, silver-coated implants to, allow to save the lower limb, which, is not something can be available easily. You have to plan for that. But we do have option for limb salvage procedure for most of the situation. So should we then, consider extended antibiotics after reimplantation? And we can discuss this with Tristan and Dr. G. That was also a question asked during the consensus meeting. And there seems to be emerging evidence that 3 months of oral antibiotics together might be useful to try to decrease the risk of early failure secondary to periprosthetic joint infection. And it was quite a moderate, agreement on that. The problem is you do the second stage and you have the cultures come back positive during reimplantation. What do you do when we know that it increased by 2 times the risk of failure? And in this situation also we should consider at least 6 weeks of antibiotics to be discussed with the team, of course. But even though we have to tell the patient that there is an increased risk of reinfection despite antibiotic administration, and it's not the optimal, situation, of course. In France, we have Eric Senneville. He was also involved in the consensus meeting, and he analyzed the role of suppressive antibiotics. Tristan has also huge experience in that, in management of PJI. And we know that there are, situations, and that's something I'm sure Tristan will discuss extensively a little bit later. We should not consider, that, maintaining, antibiotics is a failure. It might be a nice way to maintain function, even if you go for two-stage, strategy. So this is my final slide showing that in some case, going for one stage, I think might be tricky. We can discuss this with Dr. G, who has a huge experience in one stage. This is situations we get referred, young patients, extensor mechanism failure, previous surgeries. You have to consider massive allografts. Really hard for me to consider this in one stage. And these are situations where I think two stage remain the gold standard. So take home message, work as a team. It's very important. We really have been working a lot in that with Tristan. Consider guidelines. Consensus FIDE is one of the guidelines. Teamwork, two-stage strategy remains sometimes very useful, and what's going on in between is crucial. Thank you very much for your attention.
Thank you so much for both of you, Dr. G and Dr. Lustig, for this wonderful and comprehensive talks. Very, very important. So now we have to move on to the first discussion part. So I would like to ask a first question to Dr. Lee about ultrasonic debridement. It's very interesting. So I suppose it is to reduce the adhesion of the bacteria and to act potentially on the bacteria that could be on biofilm. Very interesting. Are you using dedicated device for that is available in your country?
Yeah, we use a dedicated device to do that ultrasonic debridement, and we use the ultrasonic debridement. I think it already be used in some other specialties like skin infection or the oral infection, and so we think that it could also be used in the peripatetic joint infection, and so we just use cavitation effect to break the biofilm and to full expose more planktonic bacteria and to increase the efficiency of the foreign chemical debridement. Get more bacteria sensitivity to the hydrogen peroxide or the polyethylene. So that's our purpose to do with ultrasonic debridement.
Okay, thank you. And just another question. Most of time during one stage exchange and during reimplantation, you are using cementless prosthesis. But if you need to use a cement, are you using single or dual antibiotic loaded bone cement or not?
We do for the hip one stage revision. We never use cemented prosthesis. We use all the prostheses are cemented.
Okay, thanks.
So Professor Ferry, I also have a question for you. And for primary hip primary knee or hip arthroplasty, so would you prolong the duration of oral prophylactic antibiotic for high-risk patients, like prolong the duration to 2 weeks after surgery? I mean, in primary hip or knee arthroplasty. Dr. Ferry?
Yes, sorry, excuse me. There's a little interruption in your question.
Okay, it's okay. I will repeat it again. And so my question is, for primary total hip or knee arthroplasty, would you prolong the duration of oral prophylactic antibiotic for high-risk patients after surgery?
Yeah, it's a very important question. Most of time, we do not prolong antimicrobial prophylaxis, but we can discuss other interventions during primary, such as decolonization of patients who have Staph aureus colonization, or using also during prosthesis exchange, if we are using cement associated prosthesis, we are using to fix the prosthesis some particular cement that you could be loaded with dual antibiotics. So we have different other interventions that we could use in combination with antimicrobial prophylaxis. But extension of the duration is finally not associated with a reduction of the risk in such patients. And my feeling is that we have to complete with other interventions.
If I can add a comment, maybe Tristan and Dr. G, we in some situation, Tristan, we when we identify like previous infection history or something like this, we do get some samples, and then you ask us sometime to treat the patient for 2 weeks until we get the results for the samples. No, correct. That's very specific situation, of course.
Yes, very specific. But in this case, the antibiotics is not so to prevent, but antibiotics to treat, waiting the results of the culture. So it's two different things. So we have to improve prophylaxis, and sometimes we use broad spectrum antibiotics, waiting the results of the culture during 2 stage to be sure that there is no superinfection to treat.
Yeah. We just need more data relevant to this topic. And I guess also the topic that discussed in 2022 CCGR meeting, and the panel discussed this topic, and we got consensus answer for this topic. And we need more data. Yeah. And Professor Lustig, I got a question for you.
Sure.
If for primary arthroplasty, if an DVT is formed before the surgery in patients with a femoral neck fracture or the intertrochanter fracture, things like that, and there is very high risk of attachment during operation. So after you finish installing the umbrella filter in veneer cover, will you perform the surgery immediately or wait for a period of time?
Well, that's a difficult question, a difficult situation. Usually we try. It's difficult to. The problem is it's a life-threatening, situation. So we might consider treating first and waiting a little bit before going into surgery. That's one of the only situation where we tend to delay a little bit the surgery. That's that's a difficult situation because, of course, for the patient is very uncomfortable, but that's one of the only one when we tend to delay a little bit.
Yeah, it's all also confuse us, and sometimes we don't know when we perform surgery or wait for a period of time. And I got another question, Professor Lustig. And for infected case, would you hold the prophylactic antibiotics until the suspected infected tissue was removed for culture, or just give the prophylactic antibiotic before the incision in revision arthroplasty?
So that's we don't do first when you do 2-stage, we don't do a 2 weeks drug holiday. We don't stop antibiotics, but then number one, every patient is managed together with Tristan as a multidisciplinary team. So we make the decision, individualized for each situation. That's very important for us. We really consider every situation as its own based on the bug that is identified, medical condition. And we, as Tristan said, we consider this differently, like prophylaxis, which is we do for every surgery we do antibiotic prophylaxis to avoid contamination from the skin. Plus, if it's a 2-stage surgery, we will continue the antibiotic regimen and wait for the 2 weeks, culture. So we get samples, we wait for the 2 weeks culture, and then we will adapt the antibiotic regimen. So it's we consider antibiotic prophylaxis for every case, but since we don't do drug holiday, we maintain, the antibiotherapy, and we adapt after 2 weeks when we get the results of the culture. So that's different from the other, strategy when you do 2-stage, but you stop antibiotics for 2 weeks before going for implantation. And a lot of our colleagues in Europe do the same. They realize that, even if you stop, the antibiotics for 2 weeks, it doesn't change the if you get positive or negative culture during reimplantation. So for us, there is no reason to stop antibiotics, before going for implantation.
So you just in 2-stage revision, you just give the prophylactic antibiotic before the incision.
Correct. It doesn't change. Yeah, because for us, it doesn't, create a negative culture. And you have some nice paper now showing that doing antibiotic prophylaxis doesn't compromise the samples you get during surgery.
Okay, thank you very much. So, Professor Ferry, I got a question for you. And if the joint space is dry during the preoperative aspiration, would you perform the saline lavage to get more fluid and for testing? Did you do that?
The question is to perform arthroscopic lavage for diagnosis before surgery.
Yeah, before surgery, if you do the aspiration, but the joint space is dry and nothing come out, and would you to inject some saline and to extract the saline for the test? Did you do that?
Okay, I understand the question. Not too much for different reasons. Because for the diagnosis of infection, you need to cultivate the liquid before surgery. If the joint is dry, it is a problem that you mentioned. To inject saline and to evaluate the culture, you have dilution, so the quantification of polymorphonuclear cells, it is not possible. And you can check culture about the liquid that you inject and you collect. But in fact, for me, there is a risk, minimum risk potentially of infection to give to the patient an infection. And finally, the decision to change prosthesis could be maintained. And finally, we will have the culture results during the prosthesis exchange. So if the joint is dry, we are not injecting saline for diagnosis of infection, because you could also have contamination of the sample during this procedure, and you could have false informations from all point of view.
Okay, thank you very much. And another question for Professor Ferry. And if besides the routine protocol, and would you do additional work for the culture-negative patients, such as NGS or 16S PCR, like that? Would you do any additional work for culture-negative patients?
Yes, very important question, because culture-negative prosthetic joint infection is a problem. It's approximately 10 to 15% of the patient. So for this patient, you have to be sure that it is culture-negative infection and not no infection. So for that, we have criteria. If the patient has fistula, a high level of polymorphonuclears or pathology positive, it's an infection, but without a microbiological diagnosis. For this patient, we are doing universal or specific PCR, but the sensitivity is low. So we have to develop NGS, you mentioned, metagenomic sequencing. So it is a future, not yet completely set up in our hospital, but it is probably the future. But with NGS, you could have a lot of signal of different pathogens that finally are not involved. So it would be the problem to to detect too much things. But in patient with culture negative, if we have signal in NGS, it could be interesting to treat the patient, but you will not have antibiogram because you do not have culture. But it is a future, I agree.
Yeah. So in your experience, sometimes the result of NGS is so complex. There are so many bacteria in that report list. So could you share some experience to about how to find the real bug of PJI from the NGS results?
Yes. So for culture negative prosthetic joint infection, or for prosthetic joint infection without positive culture, but a lot of things in NGS, I think it could be an indication of broad spectrum antibiotics during the 3 months, so the whole duration. So it's a little bit invasive for the patient because most of time we are prescribing broad spectrum intravenous antibiotics during the whole duration of the treatment. So this is our experience, but again, we are not doing too much NGS at this time. But for this patient, I think we have to use broad spectrum antibiotics.
Yeah. Thank you, Professor Ferry. And my question about this NGS is that when we get the results of NGS, and that report list always lists a lot of bacteria from one patient, like that, but we don't know which bacteria is the real bug to cause the infection. So, do you have any experience to distinguish which one bug is the real pathogen for that infection? Do you have any experience to read the results of the NGS?
Yes, it's a big problem because it is impossible to know which bacteria is responsible for infection, or if all of them are there. That's why we have not dedicated experience to determine which one is a culprit responsible for infection. That's why I'm thinking that for this kind of patient, we have to use broad spectrum antibiotics.
Okay, thank you. I got another question for Professor Lustig. For patients with confirmed fungal infections, what antibiotics would you add to the bone cement in spacer?
So the problem is that fungal infection is that if you add antifungal antibiotics to the cement, the quality of the cement is gets very low. So we are facing problems with the biomechanical property of the spacer.
Yeah.
So that's where we so if you do that, we cannot allow the patient to white bear. It's really hard to mobilize because you are afraid of fracture of the spacer. So that's one of the tricky conditions. I know you have really huge experience in that situation. This is for us one of the worst situation. We're lucky because we don't have this situation so often in in Europe. But when this is the case, we really are very careful with mobilizing the patient, and the quality of the spacer is not as good as when we consider other antibiotic added to the cement.
Okay, thank you very much. Another question about the discontinuing intravenous antibiotics after spacer implantation. And Professor Lustig, what are the criteria for you to discontinue the intravenous antibiotics after the spacer has been implanted? What's your criteria? The CRP ESR normal or something like that?
So yeah, two situations. I think
want to stop the intravenous antibiotics after the operation.
Yeah, so for us, let's say most of standard of care, we don't stop antibiotics because with Tristan, we try to decrease as much as possible the interval time between explantation and reimplantation. So we don't do antibiotic holiday. So that's the standard of care. But if we go for long-term interval, because of local condition, soft tissue coverage strategy or medical condition, then we might consider stopping antibiotics. And Tristan, I think you will confirm that. And then in this situation, we might consider stopping antibiotics and then aspirating the joint to make sure there is no remaining infection. But even though we will still consider there might be still some infection, and consider second stage as a primary with synovectomy, samples, large broad antibiotics, and then waiting for 2 weeks for the culture to then getting more specific. So I would say most of the time we don't do drug holiday until we go for a long-term interval, and then we stop the antibiotics before reimplantation. But that's not the standard of care for us. Tristan, you might add something?
Yes, and to complete the answer, we frequently start the broad-spectrum antibiotics after exchange of after explantation, for instance, broad spectrum targeted orally if possible, and then at the time of reimplantation under antibiotics that target the initial pathogen, we are starting again broad spectrum, waiting the results of the perioperative samples, and if there is a new infection, we are targeting the initial pathogen, and the second one identified during the reimplantation step. And if there is no superinfection, we are stopping intravenous infection and coming back to oral treatment to finally treat the initial pathogen responsible for infection during a total duration of 3 months.
Okay, thank you very much.
Can I ask a question for you, Dr. G?
Oh, okay, sure.
Yeah. You showed us very nicely your one stage, experience, which is very impressive, and really congratulations for all the work you've been doing and publishing. And I would be interested in your strategy for knee specifically, because as we said, for the hip, most of the time we use cementless, but for the knee, which cement do you use? Do you use as we might discuss double antibiotic loaded cement, or do you have specific cement you're using for the one stage exchange?
You mean for infected knee?
Correct.
Which cement we use? Yeah, we use Palatalk cement, and basically with no antibiotics in that. So we just do the direct intra-articular antibiotic injection after operation. So we think that the local use of antibiotics could provide the high concentration, and we do it once daily and for around 2 weeks. So we think that is an effective way to provide high concentration of antibiotics.
Yeah, that's what I thought. You because the way you're doing it, you provide very high dose, locally antibiotics, and you don't have to consider the one in the cement. Makes sense.
Yeah. So we just if we think the biomarker of infection just decreased to the normal level or near the normal level, we just ask the patient to vary. We don't worry about the strength of the cement. That's our experience.
Thank you.
I got another question, Professor Lustig. And what's your anticoagulation protocol after spacer implantation for infected patients? And I really get confused in my practice. Sometimes if the patient gets a DVT after the surgery, but we know that we have to balancing the control, the infection and the anticoagulation. So that's a very hard problem, I think. So I want to know your experience about that.
So we are just, for now in France, we are just starting to consider different options for thromboprophylaxis. We used to use only a low molecular weight, heparin for everyone. Now we're going to more aspirin for in some specific condition, but still for infection revision in between with spacers, we have only partial weight bearing most of the time. So we still let them under, thromboprophylaxis regimen with a low, molecular weight, heparin, usually thromboprophylactic dose, for the 6 weeks until we go back for implantation. So we are afraid of DVT, and so we maintain thromboprophylaxis, even though I know that hematoma is a high risk of, septic failure, but we still maintain them under thromboprophylaxis. But as I showed, we did a recent publication about combined work with our anesthetist. So they see every single patient, in between, and they reconsider optimization, and thromboprophylaxis is one of the parameters. So we do adapt the treatment, but most of them remained under thromboprophylaxis treatment.
Thank you. Thank you very much, Professor Lustig. Okay, now let's move to the third part of the seminar and to find out Dr. Ferry's perspective on his PJI treatment experience. And Dr. Tristan Ferry is co-head of the Infections and Tropical Disease Unit in Hospice Civils Berlin, and the head of the Referential Center for the Management of Complex Bone and Joint Infection. And his main topic of research is the promotion of innovative treatments by systemic or local administrations in patients with bone and joint infection to keep the function. Currently, he is a member of the European Bone and Joint Society, Infection Society, and member of the European Society of Clinical Microbiology and Infectious Disease Study Group for Implant-Associated Infections, and founder of the study group for non-traditional antimicrobials that includes the bacteriophage. Founder of the Phage in Line clinical program that aims to develop phage therapy in France. Let's welcome to Dr. Ferry. Let's welcome to Dr. Tristan Ferry to give a speech on innovative medical interventions to keep functioning in patients with a PJI.
Thank you so much for the introduction, and thank you so much for giving me the opportunity to do this talk. So how to keep functioning in patients with a prosthetic joint infection through innovative medical interventions. So as you know, in patients with a prosthetic joint infection, the infection could be an acute infection or a chronic infection based on the pathophysiology and the production of bacterial biofilm, that is a glue, a product by the pathogen, that could be a challenge to treat. That's why in patients with acute infection, we are doing a DARE, debridement, antibiotics, and implant retention, so a conservative approach. And that's why during chronic infection, when you have a lot of biofilm, you need to perform prosthesis exchange, 1 stage or 2 stage, followed by antibiotics. And the prosthesis exchange is here to cure mechanical problems, but also to eradicate the biofilm. In fact, sometimes it is discussed to perform during chronic infection a DARE. Why it is not so frequent to do? Because you have a lot of biofilm, and if you are doing a DARE, conservative approach, during a patient with chronic infection, as you can see, when you increase the time from prosthesis implantation to DARE, the risk of failure is increasing drastically because of the biofilm and the chronic infection that is still in place. So if you would like to use a conservative approach, so a DARE, in patients with chronic infection, it is possible, especially in patients without loosening, without mechanical problem, but we need to use suppressive antimicrobial therapy called SAT, because it is not possible to cure the patient, but we are using prolonged antimicrobial therapy to avoid replication of the bacteria and to control the disease. So this is SAT, suppressive antimicrobial therapy, well described in the Spanish guidelines, especially for patients unsuitable for implant removal, especially due to baseline condition, poor functional outcome is prosthesis exchange is performed. So the patient needs to continue antibiotics lifelong or for the life of the prosthesis that is treated. And 10 years ago, in the American guidelines, there is a topic on suppressive antimicrobial therapy. And as you can see, most of the antibiotics that are used are oral drugs, beta-lactam, clindamycin, cotrimoxazole, or tetracycline. But finally, suppressive antimicrobial therapy is not perfect, but because, as you can see here, suppressive antimicrobial therapy does not always prevent a failure, especially because some patients have no surgery at all, no DARE, so no reduction of the inoculum, or the patient could have no primary antimicrobial therapy. They are directly use simple oral treatment that could impact the success of suppressive antimicrobial therapy. So we need to imagine what could be the medical innovative strategies that could increase the rate of success of suppressive antimicrobial therapy, and so to keep the function. So we are working with Sebastian in Referral Center for the Management of Complex Bone and Joint Infection in the Lyon University Hospitals. As you can see, thanks to our expertise, the patients are coming from so far in our hospital. And the concept is to use sometimes no prosthesis exchange, but a conservative approach in particular patients. And my job is to find additional intervention to improve the infection control of these patients. And we have, for instance, some subcutaneous suppressive antimicrobial treatment, especially for patients infected with multi-resistant pathogen for whom there is no oral option. It could be discussed for some patients with big implants, very difficult to exchange. And if there is no loosening, even if the pathogen could be not susceptible to oral option, we developed OSCAT, that is outpatient subcutaneous antimicrobial therapy. It is the use of intravenous antibiotics that we could give to the patient subcutaneously with a very small needle. We published some paper on that field, and we are using particular drugs that have a long half-life, such as ceftriaxone, ertapenem, ceftazidime, or cefepime. And we are using pharmacokinetic, pharmacodynamic dosage individualization in such patients. You can see here, this is a blood measurement of the antibiotics in a patient receiving ertapenem intravenously. We are checking the blood results, and my colleagues, pharmacologist, is doing modelization to see what would be the exposition to the antibiotic in patient receiving the drug, only 1 gram on Monday, 1 gram on Wednesday, and 1 gram on Friday, 2 gram on Friday, sorry. And depending on the MIC of the pathogen, it is possible to have clinical control with this kind of management and injection only 3 times in a week. So very nice development. Other potential intervention that we could do is to perform local antibiotics in patients with chronic infection for whom we would like to not exchange the prosthesis due to risk of complication. So you mentioned that it is possible to use antibiotics locally. For us, we are not using tubes to inject local antibiotics because there is a risk of superinfection, and maybe the future is to use local antibiotics with carrier that could be hydrogel, or that could be antibiotic-loaded calcium sulfate beads that are bone substitute, frequently used for osteomyelitis, but we could use potentially this kind of beads loaded with antibiotics. For instance, it's possible to load these beads with vancomycin and gentamicin at the time of surgery. So it is carrier of antibiotics to have the ability to deliver antibiotic during more than 2 weeks, as you can see. And this bone substitute has the ability to liquefy during time. But there is a little risk of discharge. So caution in patients for whom wound closure could be difficult, and we have to have more clinical data in this field. The final interventions that we would like to develop is the bacteriophages. Very important topic here to increase the clinical success of conservative approach in patients with chronic infection. So what is a phages? It is a virus, specific virus that infect bacteria. And in fact, bacteria have also their pandemia. Because when you are sampling in the ocean in different depths, the water in the ocean, you can find a lot of bacteria, and close to the bacteria, you have some phages. But the phage could give advantage to bacteria, virulence factor, antimicrobial resistant, or resistant to immune function. But some phages could be virulent for the bacteria, could replicate inside, produce a lysine that disrupt the cell wall of the bacteria with autoamplification process of the phages that infect the bacteria. And this autoamplification process could be very interesting to control the bacteria. And finally, phages have 2 ways of action. They limit the bacterial replication, very important. And most of time, they have antibiofilm effect that is synergistic with antibiotics, that is crucial in patients with implant-associated infection. That's why we have a dedicated program to develop phage therapy in Lyon, called Phage in Lyon Clinic, dedicated to phage therapy as defined by the WHO as non-traditional antibacterials. We are doing that in close relationship with the French Health Authority. We integrated the phage therapy center in our referral center for complex pulmonary infection for patients in dead-end clinical situation or at high risk of significant loss of function. We are using pharmaceutical grade only, so we have to work with the healthcare authority. These phages fulfill a list of quality controls. We need to perform before phage application phagogram. It's like antibiogram. It's to be sure that the phage you are using has the ability to infect the bacteria and have antibacterial effect. We are using combination of phages in cocktail, and it is very complex to set up because we need to have a hospital pharmacist who mix and prepare the cocktail of phages under sterile condition at the time of injection just before surgery. So it's a huge organization that we need to have if you want to develop phages. So we published a lot of paper about the use of phages in patients with bone and joint infection, and particularly prosthetic joint infection. We published some case reports, some case series. We published also phages with a carrier such as hydrogel. We are using phages for multi-drug resistant Pseudomonas aeruginosa infection. And for me, the most important indication could be patients with chronic prosthetic hip infection for whom the surgeon think that revision could be associated with loss of function. And at this time, for this patient, we are using a conservative approach, such as open or arthroscopic DARE, and we're using phages during DARE. So we published this little case series in patients with relapsing Staphylococcus prosthetic knee infection, for whom we set up a protocol called PhagoDARE, is the use of phage during DARE. So this is typical patients that we have, elderly patients with chronic prosthetic left knee infection. The patient already experienced chronic Staph aureus infection. He already had DARE and suppressive treatment, and we have a relapse, very complex clinical and orthopedic situation. And for this kind of patient, we are doing another DARE because revision is very complex. And we are thinking about different exposition with subsequent injections under sonography that we could have to try to control the disease, especially in case of relapse. And we submitted to the ECCMID an abstract that has been selected as top-rated abstract next month in Copenhagen. So this is typical patient for whom DARE has been done. DARE facilitates the reduction of the inocula, and then the surgeon closes the joint. And there, as you can see in this liquid, we have billions of viral particles that have the ability to infect the Staph aureus strain of the patient. So we hope to have antibiofilm effect, and we hope to have effect on the bacterial strain. So we are doing one-shot injection during DARE. And after that, remember that the infection was uncontrolled in this patient despite antibiotics. And after that, it was possible for the patient to walk, no pain, and no clinical signs of infection. So the phages help here to control the infection. But and the outcome was very nice. At 2 years, we published this case in this paper. But finally, during extended follow-up, the patient experienced a relapse under suppressive antimicrobial therapy with the same Staph aureus strain that was still susceptible to phages. And we set up a particular salvage intervention that was no surgery at all, but injections of active phages with a 1 week interval. Again, no tubes to avoid superinfection. And we injected in this patient dedicated active phages under sonography in the abscess that was in communication with the joint. As you can see here, I simply added doxycycline, 1 pill orally as suppressive treatment. And we had this kind of effect, again, without surgery, perfect control of the disease with the phages and the suppressive antimicrobial therapy. And again, the infection control process was nice during 2 years following this intervention. After that, the patient died from other problems, cardiac problems, without any pain, without any clinical signs of infection. So a very nice option to control the disease in elderly patients. So we set up a randomized clinical trial in France and Spain called PhagoDARE-1 with the company that provided the phages in patients with chronic prosthetic joint infection requiring DARE plus suppressive antibiotics. It is a randomized clinical trial, the patient during the DARE receiving phages or placebo. And we set up also the salvage procedure with injections during sonography in patients for both arms during the follow-up. We have also set up phage therapy, in particular patients with contraindicated to open DARE. So you know that arthroscopy has no place at all for the treatment of prosthetic infection. But in fact, it could be useful because it is a minimally invasive procedure and we could put the phages during surgery. You have no risk of superinfection because it is not open surgery and it is nice for the patient. We publish this case and it could be also an option for the future. So we set up phage therapy center. We treated 54 patients at this time, mainly with the phages from a French company called Ferricides, but we are using also phages from different origin, and we can set up a public production of phages. Most of the patients had prosthetic joint infection. This is the most interesting indication, and it opened the door to treat other indication. And we helped some colleagues in Sweden, but also in Switzerland, to treat some patients with phages. And as you can see, half of the patient had multi-drug resistant pathogen, and we have phages only against Staph aureus and against Pseudomonas aeruginosa. So it's one of the limitations. And we developed also another way of treatment with lysines, that is only the enzyme of phages that is active on Staph epi. And we will have clinical trials in the field. Thanks to this experience, the French Health Ministry gave us the ability to centralize the request for phage therapy in patients with complex spongial infection in France. So we would like to increase our experience in the field and to perform clinical trials. So conservative approach and the DARE could be proposed to patients with chronic prosthetic joint infection without clinically significant loosening, especially for elderly patients or for patients with past revision or patients with rejection prosthesis without loosening. Multidisciplinary management with infectious disease physician is crucial to imagine to manage this patient. These patients have indication of suppressive antimicrobial therapy to control the disease. And I think there is a huge place to increase the success of SAT by subcutaneous suppressive treatment, by the use of local antibiotics with carrier, and also with the use of bacteriophages. And the future is fantastic because we will have a lot of clinical trials in the field. I would like to acknowledge all my colleagues in Lyon, especially my colleagues in the infectious disease building that you can see here. And don't hesitate to check our website, to follow up on social media. And thank you so much for your attention.
Thank you, Professor Ferry. Thank you very much for your great presentation. And congratulations for your huge successful phage therapy on bone joint infection. And let's move to the discussion section of this seminar. And Professor Ferry, I got a question. In your presentation, I saw that outpatient subcutaneous antimicrobial therapy, that's a very interesting concept. And I wondered, is there any antibiotics be approved for treatment in the subcutaneous way? Is there any antibiotics?
Yes.
Or which type of antibiotics are suitable for the subcutaneous injection?
So it's a very good question because there is no antibiotics that have approval for subcutaneous treatment because there is a risk of skin necrosis. But in fact, in our experience, we are using off-label subcutaneous treatment, but we are doing everything to avoid skin necrosis. And if you want to avoid skin necrosis could be associated with particular drugs, with the speed of injection, and with dilution. Mm-hmm. And to avoid that, we are using only some antibiotics, ertapenem, ceftriaxone, cefepime, ceftazidime. And with these antibiotics, when you are performing a dilution in 50 milliliters, and when you are doing infusion by gravity, no direct infusion, but infusion by gravity during 30 to 45 minutes, we did not observe any skin necrosis. So it's an outpatient practice and off-label practice, but based on our experience, it could be very interesting for some patients infected with pathogen for whom there is no oral options. And so it's very important program, and I'm sure it could be very interesting for patients to avoid subsequent difficult revisions and complications.
Thank you very much. And I wonder that if the patient did the subcutaneous injection of antibiotics, they could did it at home or at the community clinic, or they just could do it by themselves.
Yeah, it's a good question. So it's outpatient management in patient without any central line to avoid infection of the central line. And most of the time it's a nurse who is coming at home to perform the infusion.
Mhm.
And especially for elderly patients, because for elderly patients, you can they have a mild kidney injury, and you can inject only on Monday, Wednesday, Friday. So it's a nurse who is coming at home. But for the youngest patient, there are some devices that could be used in the future. And maybe for the youngest patient, the drug could be used by the patient itself to be injected. But the young patient has a nice kidney function, so elimination of the drug. So they need to inject the drug probably every day. But there is some projects to produce some particular device that could be used at home.
Wow, that's an amazing way to use antibiotics. And but if for young patients, if you do the subcutaneous antibiotic injection by themselves, how do they know when to stop the medication, or it's just the dosage?
Yes, that's why suppressive subcutaneous treatment is not so much for young people. And for young people, probably that you have to consider more revision. And for at the opposite, for elderly people who previously experienced a lot of revisions, subcutaneous treatment could be a good way. And by a nurse at home, it's the simplest way. And they accept that.
Yeah.
So it's subcutaneous treatment to keep the function.
To keep the function. Yeah, that's great. And another question about the phage therapy. The phage as an antibacterial agent that we use in human body. And I don't know, is there any report on the phage pharmacology studies in humans?
So it's a good question. So phages are natural phages from environments that are purified, and we inject a virus to the patient. So there is two different questions. The first is the safety. So there is no, this phages has not the ability to infect human cells. And if the phages is purified correctly, there is no particular risk. And there is very few data about pharmacokinetic. It's a crucial question because when you inject the phages locally or intravenously, there is a clearance of the phages. But if the phage catch the bacteria, there is amplification. So we have to know what would be the pharmacodynamic and pharmacokinetic way of action of phages in infected patients. It's a very important question and very important element that we need. Absolutely.
Yeah. It's a key point. If we want to use the phage widely, and and another question, and you except you mentioned in your presentation that I think that's very interesting. You call it the phage cocktail, and as we all know, that's one limitation of phage therapy is its narrow specificity against only single pathogen. And so the paper always say that the phage therapy should be prepared individually and cataloged in phage bank, tested for the effectiveness against the passengers isolated from particular patients. So however, in your presentation, you call the phage cocktail. Seems like that's a broad spectrum phage. Is this the synthetic biology approach feasible in your hospital?
Yeah, so it's a good question. We are not using phages empirically. So all the phages we are using, we need to demonstrate the in vitro activity before. So we are using cocktail of active phages. It is just to avoid acquisition of phage resistance, because when you are using only one phage, especially without antibiotics, there is a risk of acquisition of resistance of the bacteria against the phage. So we are using phages plus antibiotics because you have synergistic effect. And we are using, if possible, cocktails of active phages to prevent the acquisition of resistance to phages. That's why we are using it in a cocktail.
Oh, I got that. So that's not the combination of different phage. That's a combination of phage and antibiotics.
Yeah, we are combined phages plus antibiotics. Yeah, but if you are using a single phage with antibiotics, even if phage and antibiotics are synergistic, there is a risk of acquisition of resistance to the phage. That's why we are using cocktail of phages, active phages with antibiotics to prevent acquisition of resistance to phages.
Right, thank you very much. Okay, I think it's time to make a summary for this episode since the time is limited. And thank you for your contribution, Professor Ferry and Professor Lustig. Would you like to offer us some take-home messages, Professor Ferry?
Yes, from my part. So, to conclude, it is very nice to see that for the patient, we have different options. We can have one-stage exchange, you mentioned that. We can have two-stage exchange, very important, especially for patients with skin and soft tissue coverage necessity. And I shown that it is possible also to imagine that a conservative approach could be done for the patient with suppressive treatment and different innovations. So finally, I think as a take-home message from my part is that we have so many different options to treat infection, and we have to choose in the different strategies what finally we are thinking that it's the best for the individual clinical situation.
Okay, thank you very much. Professor Lustig, could you offer us some key points?
Sure, of course. So what is interesting is to see how we've been evolving since 1983 and John Insull, like two-stage, old-fashioned way to treat every single, PJI infection to now a more, I think, modern way with different options, but more and more conservative. You've shown, Dr. G, your extensive experience with one stage, very impressive, and how you try to decrease, the part of the two-stage strategy. And Tristan Ferry showed also nicely how with a new treatment option, we can also improve the part of the conservative treatment. So I think in the future, we're going to be more conservative, more and more. And with the two options we discussed, one stage and conservative treatment. And the two-stage strategy is going to be the exception. But for now, it's still important to know how to manage all the different situations because PJI is still a very common due to numbers of primary joint we do. We still have some, difficult infection to treat, and it's very important to have experts such as yourself, Tristan Ferry, and our group to know how to make the right decision.
Thank you, Professor Lustig. Last, I want to thank Arthroplasty Society in Asia for providing us the opportunity to participate in this online seminar. By the way, we organized a special issue on PJI in the Journal of Arthroplasty led by Professor Li Cao and Professor Javed Parvizi, aiming at consolidating our understanding on prevention, diagnosis, and the treatment of PJI from basic etiology research to the clinical translation therapy. It was a very successful special issue. And in this year, we are planning to establish the section on infection for the arthroplasty. We do encourage researchers to contribute to original research articles and works related to this topic.
Yes, okay, everyone. So this is the end of the first episode of Asia Novel Seminar Session 4. So thank you so much to all participants and thank you for watching. Stay tuned and see you next time. Thank you so much and bye-bye.
Bye-bye.